Our next speaker is our friend Dr. Mohamed Sameh Abdullatif. دكتور سامح الحقيقة أنا عاشرته وهو نائب صغير معانا في القصر العيني قبل ما يهاجر إلى المملكة المتحدة. الحقيقة محمد سامح من صغره الحقيقة من الشخصيات الأكتيف الساينتفك. He is a critical care consultant. He is exam board in Royal College of Anesthesia. He's acting now in Stepping Hill Hospital in Manchester. He's a well-known name in anesthesia and ICU. He's talk today about echocardiography and change of practice in intensive care. تفضل دكتور محمد.
شكرا. First of all, I'd like to say that it's an honor and privilege to be back to Alainy. I'd like to say that it's my department. Actually, thanks very much for the nice introduction. A special thanks to Dr. Islam. Without him, this presentation wouldn't have been there, to be honest, actually. So my presentation today is about echocardiography from evolution to revolution in the sense of the journey, actually, how it comes to where we are today, actually practicing echocardiography over the years. So what I'm going to talk about today is the journey and the change of tide, actually, where the tide charge changed to using echocardiography, evidence behind this change, what were the missing links between hemodynamic monitoring, the routine one, and our echocardiography nowadays, how echo changed the current practice, a little bit about training, because it is an issue, still an issue, and then message take home. So let's start with the journey. How did it all start, actually? It all starts from it's a little bit of a cook-up. Is it coming or not? Right. It is actually coming now, very slowly. So the main issue in the past, actually the main obstacle is the fact that if we need echocardiography, cardiologist has to do it, actually, and there's no 24/7 echocardiography basically cover for ICU all the time. The second issue is the training, main issue really, because to train ultrasound like any other skill, you have to have the time and you have to spend the time to be practicing on it and to practice actually ultrasound and echocardiography. But having said that, it is it's a running issue until now really. And then finally in 1980s, the group of anesthetists starts to talk about spending some more time in training and having accreditation process to make sure that the ultrasound or the echocardiography of the heart starts to be part of the comprehensive and global assessment of the hemodynamics of these patients, really. It's all frozen, I'm afraid, but anyway, it's well coming up. So evidence starts to pile up, especially in cases where actually using pulmonary outflotation catheter, but the reading are not making sense. In 1996, the Association of Anesthetists, American Society of Anesthetists, and the Society of Cardiovascular Anesthetists in the States starts to talk about, or got some evidence really, and categorize the evidence behind using echocardiography in ICU into three categories, where it is useful in improving the outcome. Category 2 might be useful. Category 3, infrequently useful. And at that time, when this came out, Category 1, where it is actually useful, said that evaluation of persistent life-threatening hemodynamic instability in ICU, where basically the ventricular function and its determinants are uncertain and have not responded to treatment. So they were very specific in this indication. Other routine indication category, like the HOCM, the aortic injury, and tamponade were there already. Category 2, basically the most striking part of this category is where the perioperative use in patients with increased hemodynamic disturbance and multiple trauma and chest patients. This starts to come up at the time as a level 2 indication. Categories 3 started to have something like intraoperative evidence of emboli during orthopedic surgery and the evidence of embolism during orthopedic surgery. Since then, there is loads of evidence to support that. Actually, that was in 1996. Don't forget that. But since then, there is loads of studies that's been done about using echo to detect this. I think the pivotal moment in the progress of this was where functional hemodynamic came up, in the sense of people actually started to use echocardiography parameters like the SVC diameters and collapsibility, and the IVC diameter and the collapsibility, in using TEE and so on and so forth to evaluate the volume status of the patients. And that's actually was a pivotal moment in the change of practice in ICU and the shift towards using more in this. In 2003, almost the same group of people, actually, the Association of Cardiology of the States and the American Society of Echocardiography, started to basically came up with new recommendations. But when you see here, actually, is number one of these categories were the hemodynamically unstable patients, full stop. If you remember from 1996, it was specific in mentioning that if the ventricular function and its determinants are uncertain and not responded to treatment, the evidence start piling towards use of echocardiography in any hemodynamically unstable patient. So the tide starts shifting at the time. And then again, in the category 2, people who start to compare using echocardiography and pulmonary artery flotation catheter. Okay, so in this number 1 indication, for example, the evaluation of hemodynamic and pulpal trauma patients and with pulmonary artery catheter monitoring, and data are desperate with clinical situations. So they started to doubt basically the figures they get from pulmonary artery catheter, which does make sense. And then eventually in 2014 starts to come other indications as well. We'll come back to this in a minute, but there's other indications like the HOCM, the PE, the right ventricular catheter, the cardiac arrest, the most recent ALS recommendations come up in 2015, encourage the using of ultrasounds in diagnostic process during the resuscitation, actually. But it was very specific in how it should be done and how much should it take. Actually, it needs an expert. Not everybody should use it. Eventually, 2014, the European Heart Journal published this paper, basically encompass all the recent evidence behind the use of echocardiography in ICU. And when I'm talking about ICU, by the way, we are only talking about general ICU. Cardiac ICU, been used for quite some time, echocardiography. I'm a general intensivist. I don't do cardiac. And this is the emphasis on this lecture, actually. So the use of ICU, the use of echo in ICU starts to go significantly higher over the last 15, 20 years, actually. This is a paper from Anton Villard-Baron, who's an eminent figure in introducing echocardiography in Europe with his colleagues, Michel Salama and Bernard Cholly. The three of them are very, very instrumental, but this paper goes back to 2008, where he found, in 2006, 2008, in their unit, the number of echocardiography done was 140 cases. Today, in our unit, we do 100 to 150 cases. Our unit is a moderate unit, it's 20-bedded one. And Antoine Villard-Baron's unit is a 40-bedded one, actually. So you all imagine how basically the echocardiography use starts to be very, very evident there. Evidence behind the change. Before we move any further, this evidence, I will categorize it into 2 categories: hemodynamic evidence and routine and emerging evidence, basically. Takes a bit longer to load, I'm afraid, sorry. Right, let's start with the hemodynamic evidence behind that, behind the change of tide and use of echocardiography in ICU. There's no doubt that high-risk surgical patients need some sort of, are at risk of increased morbidity and mortality, of course, so they need to monitor their cardiac output. And it's all accepted now that arterial blood pressure is not cardiac output. It's all accepted, this fact now all over the world, really. So what we need to do is just to monitor them with something else, actually. And we all know that pulmonary artery filtration catheter, despite being the fact that of the gold standard for cardiac output monitor, there is actually defaults where we cannot rely on the pulmonary artery filtration catheter. So the fact that left ventricular end diastolic pressure is equivalent to the preload of the left ventricle, and that's been reflected by the left atrium, and that's been reflected by pulmonary artery capillary wedge pressure, is all gone now, actually. There are certain situations like change in the left ventricular compliance, change in the pulmonary venous obstruction, like with atrial myxoma and pulmonary fibrosis, which we get a lot with ARDS nowadays, reduced pulmonary vascular bed, like with patients with pneumonectomies. All these situations, you cannot rely on pulmonary artery catheter to give you reliable figures in this. Evidence are piling comparing the two. With this paper by Pollard showing that in patient pulmonary artery catheter, there were 44% underwent change of therapy after having a TEE done. So the patient has a pulmonary artery catheter, they have an echo, afterwards there was a change of treatment. Another paper came up by Benjamin that showed as well that there is another 55% of disparity in the 55% of the cases between the pulmonary artery figures and the echo figures, and the myocardial function were different in 39% of the cases. The most important thing, in my opinion, was there was a change in management in 58% of the cases, and that's what's significant to me. The third paper came from a colleague of mine, actually, from Cheltenham and Gloucester. I like this paper because A, it reflects quite well the size of our unit. It's a small unit, like a 20-bedded one. It's a general district hospital. And again, it shows the same result. There is a change in practice after using echocardiography, but also, more importantly, showed that we use this paper actually to guide the limitation of treatment. There's certain patients that you shouldn't really escalate the treatment for. And he used the data from echocardiography to put limits to the treatment of this patient, which I think is as important as the treatment itself. Add to all that the complication to have from the pulmonary artery catheter, that was a drive towards using the echocardiography. People can basically argue that we can use pulse control cardiac output monitor. We don't have to use pulmonary artery catheter, which is true, and that's evidenced by this paper from Neil Sonny from Chelsea and Westminster in 2003, showing a very good bias limits and limits of agreement between pulmonary artery filtration catheter and other cardiac output monitor. And you've got plenty of figures to rely on. But there's no doubt that they're both invasive. They both have, with any swing in the systemic vascular resistance, they have to recalibrate them again. Basically, they don't reflect the left ventricular compliance, and they all have rehabilitations actually when the AF happens. You have to recalibrate them again. For the purpose of evidence behind the change for the routine and emerging indications like the HOCM, the PE, I choose to demonstrate some cases from our unit, really, just to show you how the change of mentality happened over the years, actually, and how it is very important now to use it as a bedside testing for this. So, first patient we have here is a 71 years old, septic patient, culture revealed urosepsis, hypertensive, otherwise fine, treated with fluids, vasopressors, antibiotics, same routine that you do according to the Surviving Sepsis campaign. Initial improvement, and then 24 hours later, this is a bit actually, you hit a brick wall. Okay, she started to deteriorate. Amazing thing is, she started to have congestive cardiac failure requiring CPAP and diuretics, which is a bit odd considering that she is vasodilated. So, echo has been done. I remember this case quite well because one of my colleagues actually called me from HDU asking my opinion about limitations of treatment. So I went, I did an echo, And the patient has hypertrophic obstructive cardiomyopathy with a systolic anterior motion abnormalities. For people who are not familiar with the systolic anterior motion abnormalities, I think cardiac anesthetists will do. But basically, in a patient with a HOCM, what happens during every systole, the anterior mitral leaflet start to be pushed towards the left ventricular outflow tract. So with every systole, basically there is very little going through the aorta, the blood accumulates behind the left ventricle, and pulmonary edema. Treatment for these patients is exactly the opposite of what you should do with straightforward pulmonary edema patient, which is give them diuretics and put them in CPAP. Give them CPAP. But what you should do is just to give them fluid, to expand the ventricle, move the fluids forward, and this is what should happen. And I can see the astonishing on my colleague's face, actually, when we started to talk about this. I said, oh, she's in heart failure. Why do you want to give her some fluid? I said, let's try it. She'll die anyway. Let's try, give her fluid and see what happens. We gave her a bit of fluid. She came off the CPAP in 2 hours. She came in high flow oxygen next morning. So this is actually where, in practice nowadays, we have to rely more on echocardiography. And evidence on the wall, she's not in congestive cardiac failure because of heart failure, because her ejection fraction, as showed here, is 60%. So it's not the systolic function. It is her left ventricular compliance and the systolic anterior motion abnormalities, which cannot be diagnosed with any other methods. You have to rely on your echo. Another patient, 69 years old lady who is basically 2 weeks of feeling unwell with the viral-like symptoms, admitted, shortness of breath, chest X-ray, as it shows here. It looks like basal ARDS to me. Type 1 respiratory failures. We accepted the lady for ICU. Intubated, ventilated. The no other recurrence start to pile up. The amazing thing about this lady is, despite the fact that she looks well filled with a CVP of 15, she's very well much squeezed with the SVR of 1500 and the cardiac index was 4. Despite that, her lactate's still high. Okay? So common sense of this, and according to the Surviving Sister campaign, the next step should be just to dilate her a little bit, get this lactate washed out. But you cannot really dilate her without assessing her cardiac function, hence the echo. So we did the echo, and this is what it showed. And I'm sorry if the videos doesn't play because obviously of the cock-up with the electronics, but if you can see on the right hand of the screen, you can see that the right ventricle is equal to side to the left ventricle, which means one thing, that there's right ventricular dilatation. This lady had a right ventricular dilatation, so there's an increased pulmonary vascular resistance, if you like. And again, it is dilated on the other view, which is the parasternal short axis view. And that's evidenced by measuring her pulmonary artery systolic pressure, which ranges between 48 and 55 in her case. So we put the lady in some prostaglandins, prostacyclin. 12 hours later, you can see the difference on even though the right border of the right ventricle is being taken out, there is a big reduction on the size of right ventricle. This lady, she's been tracked on that day, came to 30% oxygen and then off the ventilator in a few days. Again, you cannot do that. You can argue the case that you can use a pulmonary artery filtration catheter, but the echo was less invasive anyway. Third case, 54 years old man, asthma, obese, otherwise fit, flu-like symptoms. He had a little bit of chest pain, which everybody assumes it's a bit of pleurisy, had nice steroid there for it. Started to have increasing shortness of breath and transferred to ICU because he's had impending respiratory failure. So we talked about patients, but as the physio started to basically get him out of bed, he had a brief cardiac arrest, back to bed, resuscitated, intubated, 100% oxygen all suddenly. Again, the videos are not working, but you can see here on the screen that the right side of the screen that there's a right ventricular dilatation, there is a bit small thrombus on the on the right atrium, so it had pulmonary embolism. Gold standard for PE is just to do a CTPA. We cannot take him out for a CTPA because in 100% oxygen unstable. So I thrombolized this man, and you can see the difference between the two cardiac images where there is a reduction on the right ventricular side. it is a life-saving. It doesn't come on the National Institute of Clinical Excellence guidelines as a strong evidence to do that. But when you cannot take patient to CT scan, to do a CTPA, your back is against the wall. You have to thrombolize these patients. And it's a 54 years old with a reasonable practice of life. And it doesn't have to be as big thrombus as this. It might be a smaller thrombus. The fourth case is, this is where limitation of treatments come into the equation. 65 years old lady, long history of ischemic heart disease and diabetes. 5 years ago, she had a myocardial infarction. Exercise tolerance about 100 yards, which is the famous figures in England when the physicians start to refer cases to you. If they don't want to look that bad, they say 100 yards. Chest pain, she had a high trop I, so she definitely had a myocardial event. The cardiologist referred her to us for CPAP plus or minus ventilation. I accepted the patient with the precondition of doing an echo for her, because putting a CPAP to her is fine. Should we go to full ventilation? Should we go for hemofiltration if the patient starts to be poorer? And that was the purpose of the echo. We've done the echo, and you can see here, she's got a posterior wall aneurysm. So this lady had a long-standing myocardial problem beyond level 3 treatment. So the decision is, we put the DNR order for the lady, we got her on CPAP, give her some diuretics, we called it a day. She got out of ICU, to be fair, but I'm not quite sure she got out of the hospital, but she wasn't for level 3 care. And that's where echo is very useful. The last final case basically is a 68 years old female, ex-smoker, again exercise tolerance about 100 yards, 5 days history of diarrhea and vomiting, admitted with septicemia, low blood pressure. She had an non-STEMI in the process while she's still in the medical wards. Referred for basically, she starts to be a bit confused, GCS low and low urine output. We did an echo. Again, the video is not playing, but as you can see, I don't know if I put an arrow here, she's got a mural thrombus at the top. She had a myocardial infarction a few days back, and she had a mural thrombus. The only difference here is 2 things, really. The differences are, A, again, she's a lady who had a DNR order because she's not for any further treatment. B, we thrombolized her. That's very, very significant, really, because it was a crucial part of our treatment, and the thrombus, as you can see at the top there, almost disappeared.
2 minutes.
Sorry, I almost finished. So how's echo changed in practice? I have to go to this slide and stop, actually, because it's may have to miss on the training. It serves 3 purposes here, actually. It's serves purposes for routine work, like obstructive shock, like patient with tamponade, aortic dissection, hypovolemia. It's definitely echocardiography in these situations is crucial. You cannot deal with the patient without them. It's other situations where the information we got from it is supportive, like PE, systolic anterior motion abnormalities, diastolic dysfunction. And the third, basically, information or type of information you can get is supplemental, like limitation of treatment and cardiac arrest. So, and there is evidence to support all that, obviously. There's this paper from 2004 that piling all the evidence together, the echocardiography data was positive in 97% of the cases. In summary, echo make you look at the whole picture. You don't look at the pressures, you don't look at the volume, you don't look at the myocardial performance. You look at the whole picture and decide on the hemodynamic and the cardiovascular treatment for these patients, not only in any single figures. Thanks very much.
Thank you, Dr. Sameh.